Oh hey, I didn't see you over there. Welcome back. Last week you learned all about PNF and its many benefits. This week I'm here to talk about muscle energy techniques and how they can be used to readjust an innominate rotation. Today we will focus on posterior rotation to correct an anteriorly rotated innominate. The patient may come to you with complaints of pain in the SI region, or maybe the patient has pain up or down the kinetic chain that you believe their obliquity is exaggerating. How do you know if your patient has a pelvic obliquity? Well, there are multiple tests you can perform in your exam that would lead you to suspect an anteriorly rotated innominate. First, when palpating, the ASIS of the affected or painful side will be lower than the uninvolved side, and the PSIS of the affected side should be higher than the uninvolved side. Another test you can perform is the supine to long sit test. The rotation has repositioned the acetabulum, which has resulted in a leg length discrepancy. While in supine, the leg of the involved side will appear longer. Then, when the patient sits up, the leg of the involved side will then appear shorter. Another test you can perform is the standing flexion test. When a patient has a fixed rotation, the anteriorly rotated innominate is stuck on the sacrum. Normally, when the patient flexes forward, the sacrum will begin to move forward with the lumbar spine first, and then the innominate and the PSIS will move forward as the hips begin to hinge. Since this patient's innominate is stuck, the PSIS of the affected side will begin in an elevated position and start to move immediately with the sacrum. The goal of this technique is to use the patient's own isometric muscle contraction to pull the rotated innominate back into place. Here, the innominate on the right is anteriorly rotated. In order to pull it back into place, we use a muscle group that has the opposite action on the innominate. In this case, the hip extensors will apply a posterior rotation force to shift the innominate back into place. Here to help me demonstrate the posterior rotation muscle energy technique is my personal physical therapist, Melanie. Position the patient supine. The patient will hang his uninvolved leg off the side of the plinth. Flex the involved hip until the freely hanging leg begins to rise. Make sure the lumbar spine does not arch off the plinth. In this position, the involved innominate is rotated into relative posterior rotation, and the uninvolved is rotated into anterior rotation, putting optimal tension on the tissues we are looking to adjust, which we call engaging the barrier. The physical therapist stands over the patient and uses her shoulder to hold the flexed knee in place. She reaches across to hold the side of the plinth for support. The patient is then instructed to push his knee into the therapist's shoulder at about 30% of his maximum force. This isometric contraction of the hip extensors is held for 5 to 10 seconds. The patient then relaxes, and the therapist uses her shoulder to stretch the patient into further flexion until the hanging leg begins to rise. This resets the barrier. The process is repeated 2 more times, each time passively moving further into flexion as the tissues permit. You can also teach your patient to perform this on their own by performing a contraction against their own resistance. Keep in mind that it is possible to overcorrect or pull the innominate too far back into posterior rotation. If that happens, you will use the anterior rotation technique to correct, which we will discuss next week. This muscle energy technique can be used on most patients that present with an innominate rotation deformity. That said, here are some patient populations you may not want to perform this on. This is just one technique you can use to adjust an innominate rotation. Check back next week to learn more about muscle energy techniques.
Shirt so sexy it hurts, and I'm too sexy for Milan, too sexy for Milan, New York and Japan.